Good afternoon, students. Today we'll be talking about central nervous system tuberculosis, and we'll be concentrating mainly on tubercular meningitis. And as you know, that it's a very devastating illness, and we'll deal in this following scheme that we'll try and introduce the topic and talk a bit about epidemiology and the manifestations of neurotuberculosis, that is TB, meningitis, tuberculomas, spinal tuberculosis only will be touching, and the management issues, multi-drug resistant CNS tuberculosis, DOTS, and tuberculosis control program, and as applicable to this. So most of you know that Mycobacterium tuberculosis is a bacillus, and this is acid fast, and it is usually the reservoir is humans only. I mean, it's not seen in animals. It can spread to animals, but the main reservoir is humans, and more than 2,000 million people are infected with tuberculosis, mainly pulmonary tuberculosis, and 200 million are at risk for developing tuberculosis, and out of these 2 million at risk for TB meningitis, which is a very lethal illness, and this is the third leading cause of mortality in developing countries. And if you look at the admissions in hospital, 2.5% of pediatric admissions to hospital are neurotuberculosis, and 7 to 8% of adult admissions to hospital are also neurotuberculosis. And HIV infection is a new risk factor which has come since about the 90s, late 90s, and we have more. So we'll show you our experience of CNS tuberculosis in AIDS cases, and also neurotuberculosis as in non-AIDS cases, and in the course of the presentation. So if you look at this, 100 to 299 cases per 1 lakh population are happening in India as per the one census in 2007. It will be around this figure even now. This is the estimated new TB cases of all forms will range up to 300 per 1 lakh population per year, and so that's very highly endemic area. And if you see the notified cases, more than 100 per 1 lakh population, and the density of tuberculosis is very high in Indian subcontinent. And if you look at the countries which have got global increase in the number of new smear positive cases, or dots made by the high burden countries, and India is definitely high burden country, and it is a contribution of 70% new positive cases are by Indians only. So that means India is endemic for tuberculosis, and all types of tuberculosis should be well known to the students, and tubercular meningitis is an illness which is very difficult to diagnose because you don't suspect it. That's the whole problem about it. And you should be aware of tubercular meningitis and its various manifestations. So if you look at the cranial tuberculosis or CNS tuberculosis, main is tuberculous meningitis. It can be with or without tuberculosis. The second is encephalopathy, which is slightly rare. Vasculopathy, you can come across various types of infarcts and vascular pathologies, occlusions of major vessels, especially anterior cerebral artery and middle cerebral artery, and you can have space occupying lesions like tuberculomas, which are single or multiple, and they may be miliary tuberculosis in association, and coagulation of many tuberculomas can lead to tuberculous abscess also, and about 10 to 15% cases, and spinal tuberculosis is also associated with tubercular meningitis. So Pott's spine and Pott's paraplegia can happen apart from tubercular meningitis, but whenever it is meningitis, meninges are present surrounding the spinal cord also. So spinal cord also affected and will lead to tubercular arachnoiditis. The arachnoid and pia mater, they will enhance. And there can be non-osseous spinal tuberculomas and spinal meningitis. So these are the CNS tuberculosis manifestations and classification. And tuberculous meningitis is the most common presentation of central nervous system tuberculosis of this acid fast bacillus, which has got protein manifestations. And incidence in patients with tuberculosis is about 7 to 12%. And AIDS epidemic, which has come in the late 80s or 90s, and earlier, before that epidemic, the world was able to control tuberculosis, and the incidence was coming down. But with the advent of AIDS, there is a re-emergence of CNS tuberculosis. Both typical and atypical mycobacteria and also multi-drug resistant cases started appearing. So what is the pathogenesis of tubercular meningitis? And you see, you must be thinking that it is a hematogenous spread from the pulmonary tuberculosis or cavitatory tuberculosis or extraneural tuberculosis, but you will be surprised to know that it's not that. The rich foci, which are located in the subpial or subependymal regions, are mostly in Sylvian fissure, they reach there when hematogenous spread have taken place early in the life, and these foci, which burst into subarachnoid space and release bacilli, and then the subarachnoid space and ventricular system will get affected and inflammation will start in the meninges. But it is not by direct hematogenous invasion by acid fast bacilli. I'll be showing the pathogenesis in next 5 to 6 slides, but try and grasp this point that the rich foci which are present and they burst into subarachnoid space. So you see the primary infections of tuberculosis. This is a perivascular primary infection with Mycobacterium tuberculosis bacilli, hematogenous spread to the brain, rich foci, that's Professor Rich, rupture or growth of rich foci, various manifestations. Meningitis, that ependyma and choroid plexus can be involved, and there will be tuberculomas and TB abscesses in the brain, border zone encephalitis, vasculitis, infarctions, obstructive hydrocephalus, communicating hydrocephalus. That's all because of the thick exudates which accumulate at the basal region. Coalescing caseating granulomas will form TB abscesses, and host reaction to tubercular protein will cause perivascular demyelination and white matter changes. So you look at this, the blood lymphocytes are here, bacteria, neutrophil is infected with bacteria, monocytes, and what happens? They are tight junctions. So they have to break the blood-brain barrier, and then only the basement membrane and the endothelial cells are really protecting inside the brain. But what happens is, when diapedesis of infected cells happens, these bacilli, they enter the brain parenchyma and they infect microglial cells, and microglial cells get activated and they release a lot of cytokines, and which are very important in the manifestations of tubercular meningitis. So diapedesis of uninfected cells is happening here, disrupted endothelium and basement membrane, and development of the rich focus with a cuff on innate and specific B cells and T cells. So this is a rich focus, and the cytokines are liberated and they are bacilli inside the rich focus, and this rich focus ruptures with spread of infection to the meninges, and that's how this is the arachnoid matter this is the matter, and this is a white matter, and this is a gray matter, and this is the CSF. And when the bacilli enter the arachnoid space, meningitis will set in. And this is a stage 2 tubercular meningitis, where you are seeing the infarcts, you are seeing the occlusion of the anterocerebral artery on the left side, totally occluded, proximal part is occluded here, and there are tuberculomas here, and there are infarcts in the brain. So that's how the apart from the meninges, which are all around the brain, and dura mater and falx cerebri and tentorium cerebelli and all that, brain parenchyma is also involved, and also the blood vessels at the base of the brain. And the sylvian fissure is the main area where the rich foci burst into subarachnoid space and develop the ring enhancing lesions with thick walls and multiple coalescing lesions at one place with cerebral edema. That is the picture of a tuberculoma, which we can differentiate from cysticercosis. So the TNF alpha is the main factor for host mediated destruction of the infected tissue. The CSF TNF alpha level correlates disease severity in pyogenic meningitis also, but there is a conflicting evidence on the role of TNF alpha in central nervous system tuberculosis. Thalidomide is an anti-TNF alpha drug, improved survival and neurological outcomes in rabbit, but a controlled trial had to be stopped in humans because of adverse events that have happened. And the presentation, how the individual presents with tubercular meningitis, you have symptoms and you have signs which are from world literature, and in the coming slides I will show you what we have seen. Headache, fever, vomiting, photophobia, anorexia. Mind you, an individual who is dull, complaining of headache and neck pain, not eating well properly, appetite has gone down, is having evening rise of temperature, the vomitings and photophobia, you should suspect tubercular meningitis. And if you examine him, you may be confused, he may have comatose individual, there will be neck stiffness in 40 to 80%, and cranial nerve palsies will be present. Any cranial nerve can be involved in 30 to 50%. Most common is, of course, sixth nerve palsy, and third nerve, and seventh nerve, and 12th nerve also can be. And then there may be infarcts which will give rise to hemiparesis, that is focal neurological deficit in 10 to 20%, and it can be paraparesis because of tubercular myelitis or pot spine and causing damage to the spinal cord. And seizures can happen in adults in 5%, in children 50% because of the tuberculosis. So these are the various manifestations which in 143 adults with tubercular meningitis and 108 adults with pyogenic bacterial meningitis, a study has been done, because mainly we'll have to differentiate between tubercular meningitis and bacterial meningitis. As you can see that neck stiffness is present more often in tubercular meningitis than in bacterial meningitis, and cranial nerve palsies are also more common in case of tubercular meningitis as compared to bacterial meningitis. Look at the CSF cells, 70 to 1000 cells in tubercular meningitis, 380 to 20,000 cells in cases of bacterial meningitis. So it is neutrophil predominant in bacterial, lymphocyte predominant in cases of tubercular meningitis. You look at the blood glucose is low in cases of pyogenic meningitis. So lactate level is normal, and it is slightly elevated in cases of bacterial meningitis. So when you can have differentiating features which the male sex and hemiplegia, that is focal neurological deficit, and cranial nerve palsies, and CSF appearance is almost clear in appearance in TBM, cloudy in case of bacterial, and protein is 180 to 490 and 80 to 730, that is more protein, that is 190 here and 270 milligram. So there are subtle differences to differentiate between pyogenic meningitis caused by the various organisms, gram-negative bacilli and gram-positive cocci. So in our cases of 95 cases, we had males 61 and females 34 with a mean age of 35 plus minus 17. We have seen all age groups. There is no history of tuberculosis in 74%. Pulmonary tuberculosis simultaneously was seen only in 12%. Disseminated tuberculosis in 4, part spine in 1, and tuberculous myelitis is in 1. So types of comorbidities, retroviral disease we have seen in 14.7%. In this group, we have seen separately neuro-AIDS cases that I will show you in a subsequent slides. The clinical symptoms are seizures, nausea, vomiting, apathy, behavioral changes, headache 65 in our presentation. So unaccounted for headache, you should be very careful. Why an individual has headache? Is it primary headache or is it secondary? Signs: Montu positivity, cranial nerve palsies, fever, meningism is in 53 cases. So meningism or stiffness of neck is an important sign. Kernick's sign, Brudzinski sign, neck stiffness. These all you have to elicit, but they may not be always present. But your clinical suspicion should be there when you have other associated features like headache, nausea, vomiting, apathy, behavioral changes, seizures, prior history of tuberculosis, fever, meningismus, cranial palsies, coma, Montu positivity. So children and adults, there are subtle differences, but seizures are more frequent in cases of children. And we can stage tubercular meningitis into 3. Stage 1 is non-specific signs and symptoms, no clouding of consciousness or neurological deficit. This will last up to 2 weeks. And stage 2 is days to weeks, lethargy and alteration in behavior, meningeal irritation, cranial nerve palsies. Stage 3 is advanced, abnormal movements, convulsions, stupor or coma, severe neurological deficits. This is a clinical staging which has been modified subsequently when Glasgow Coma Scale has come into vogue, and grade 1 is alert and oriented without focal deficit. Grade 2 is Glasgow Coma Score of 10 to 14 with or without focal neurological deficit, or GCS of 15 with focal neurological deficit. And grade 3 is GCS is less than 10 with or without focal neurological deficit. So this Glasgow Coma Scale is applied to tubercular meningitis and grading has been modified subsequently. The staging of TBM in our 95 cases, we encountered 40 of stage 1 and 27 of stage 2 and 28 of stage 3 cases, right? And diagnosis, there are difficulties in diagnosis because the features are non-specific clinical features. You have to really suspecting tubercular meningitis, and if you miss, that's a tragedy. You should not miss. So any individual with headache, neck pain, dull, and which is progressing over 2 weeks or 3 weeks, and mild behavioral changes, confusional states, seizures, and focal neurological deficits with fever and constitutional symptoms of loss of weight and appetite, you should think of tubercular meningitis. And difficulty is also because of the paucity of bacilli in CSF. There are only 10 to 100 colonies per ml in CSF, and which is very difficult to isolate and demonstrate. The diagnostic methods are not properly assessed. So CSF study of course forms the cornerstone, but that is only suggestive of tubercular meningitis, not confirmatory, not diagnostic. So it can be seen that early diagnosis was seen in 66% of our cases, but you see 34% the diagnosis was delayed, and these people will go into a lot of complications and sequelae, because tubercular meningitis is a devastating, lethal illness. So we'll have problems if we don't suspect and start appropriate treatment. The scoring system helps us. The scoring system brought out by Thwaites, which shows, let's look at this scoring system. If age is more than 36 years, it gives 2. And if it is less than 36, 0. Total WBC count in the peripheral count more than 15,000, you give 4 points. That is pyogenic meningitis indication. Less than 15,000, you give 0 points. History of illness, 4 days or 6 days, more than 6 days, -5. That is tubercular meningitis suggestion. Less than 6, it is 0. And CSF examination, the WBC count, if it is more than 750, it is 3 points and suggestive of pyogenic meningitis. If it is less than 750, it is 0. And neutrophils in CSF, if they are more than 90, it is pyogenic meningitis, and less than 90, it is tubercular meningitis. The interpretation of this Thwaites scoring system is that more than 4, it is non-tuberculous. More than 4 is non-tuberculous or pyogenic meningitis. Less than 4 is indicative of tubercular meningitis. That's good. So the main cornerstone of diagnosis is CSF. CSF, has 3 aspects which you have to realize, that the CSF sample, if it is a large sample and centrifuged, the yield of AFB in CSF or culture is much better. In CSF examination, you look at the biochemistry, you look at the proteins, you look at the sugars, you look at the cell counts, and you look at the bacteriology studies. The 4th bottle or 5th bottle of the CSF, when you do CSF examination, is to be sent for cell count, so that you can avoid the traumatic CSF confusion in this. The proteins are usually more than 100, the cell counts are also more than 80 to 100, and predominant lymphocytes, and there may be hypoglycoresia. That means the blood sugar has to be done simultaneously, and CSF sugar will be less than half of the blood sugar. And you can demonstrate AFB in CSF on Gill-Nielsen staining, or you can put it on the culture, and you can culture, and now gene expert studies, the PCR tests also are very much in vogue, and you can look for evidence of extraneural tuberculosis, that is pulmonary or lymph nodal or abdominal tuberculosis. And lastly, you will have to depend on your clinical hunch and see the response to anti-tubercular treatment. And these are the main constituents of Ahuja diagnostic criteria, which are widely used in Indian setting. And the PCR is the now it has modified the our diagnostic approach, and the molecular diagnosis sensitivity is 56, specificity is 98%. That means you never use this test to rule out the diagnosis, because it rules in the diagnosis. Specificity is 98% and confirmation, but the sensitivity is only 56%. So even if it is negative, it is still possible that the diagnosis of tubercular meningitis holds good. The relation to treatment, and before ATT bacteriology, molecular diagnosis PCR. After ATT, molecular diagnosis of PCR is more useful. That means before starting ATT, we try and do as much as bacteriology studies and don't go for molecular diagnosis. But once you start ATT, then you have to depend on PCR. The Indian studies, the recovery of AFB in CSF is 25 to 45% only. This increases when HIV infection is there. PCR detected MTB genome in 85% of clinically suspected TBM, and it was also positive in 6% of non-tuberculous controls also. So there is a false positivity rate also. So you have to really correlate with your clinical picture, the CSF examination. So now you have suspect your symptoms, your signs, you suspect tubercular meningitis, and you look for extraneural tuberculosis. You did a chest X-ray or HRCT chest or a CT chest, ultrasound abdomen. Then you look for lymph nodes. You may do a lymph node biopsy. Then you do a Montu test also. Then you do CSF examination, and CSF examination is a cornerstone for diagnosis of tubercular meningitis, right? So after that, what to do is clinical variables predictive of TBM are symptoms should be more than 6 days, which we saw in Thwaites criteria. If there are optic symptoms and you find optic atrophy, focal neurological deficits, abnormal movements, and neutrophils are less than 50% of the total CSF WBC count. So the sensitivity and specificity, if one feature is present, is 98% and 44%. If more than 3 features are present, the specificity jumps to 98%. So an individual who has got fever more than 6 days, constitutional symptoms, headache, neck pain, mild behavioral changes, confusional state, and if he is a diabetic or HIV individual, you should suspect that he may be having tubercular meningitis. The yield of CSF smear examination, which is 45%, can be improved if you examine the deposit on centrifugation of a 10 ml CSF sample. Examine the deposit for at least 30 minutes. Examine several CSF samples over a few days. Repeated sampling increases Jaden stain sensitivity to more than 80%. So whatever we have by CSF examination, we can increase the positivity. And CSF is usually appearance is clear in 80 to 90%. The opening pressure is raised 25 centimeters in 50%. The total leukocyte count, as I said, is 5 to 1000, and you can say 100 per ml. Neutrophils are predominant in about 10 to 70%. Lymphocytes are 30 to 90%. The protein ranges from 45 to 250. The lactate level ranges from 5 to 10, and CSF glucose to blood glucose ratio is 0.5 in 95%. This is what is in world literature, and what we saw in our cases I'll show you. And we had median white blood cells are 140, the interquartile range is 270, median glucose is 47, we had median protein is 133, and adenosine deaminase is 7.9 in our 95 cases of tubercular meningitis. So ADA is adenosine deaminase levels in TBM, they are higher in TBM than in viral, bacterial and malignant diseases. A value that is more than 15 units per liter is a strong indication of TB meningitis. However, it has limited utility in HIV associated CNS TB. Now, the lab diagnosis of tubercular meningitis mainly centers around CSF examination, and the biochemistry, the protein, the sugars, the cells, the bacteriology, the AFB staining, and the cultures and gene expert, the first cultures, and also in the ADA levels. So you see the predominant cell in bacterial is polymorphonuclear leukocyte. In tuberculosis, viral, fungal, serous, neoplastic is all monocytes. The glucose is very low in bacterial, 0 to 10, but it is low. Hypoglycorrhea is in tuberculosis, viral it is normal, fungal it is low, and neoplastic it is low or normal, serous is normal. Staining characteristics, gram stain, Jaden stain and India ink are bacterial, tubercular and fungal, and cultures also are different. You can see the cultures. So you can see the radiology here. What happens in tubercular meningitis? Radiological features of tubercular meningitis, I can show you. These are the exudates. Thick exudate is getting accumulated at the base of the brain, and you see the ventricles are dilated. That means hydrocephalus, because the exudates are blocking the CSF pathways. You can see that these are the exudates, and they are encasing the blood vessels also, mainly the anterior cerebral artery and the middle cerebral artery. These are the tuberculomas in association with hydrocephalus. The third ventricle is enlarged. the lateral ventricles are enlarged, the temporal horns are enlarged. This is the characteristic of tubercular meningitis. So infarcts, basically basal ganglia, cortical, and these are the proximal vessels are occluded, lenticulostriate branches are occluded, the thalamostriate branches are occluded, the anterocerebral artery, proximal part, middle cerebral artery, the granulomas, hydrocephalus, basal exudates, and so these are the various manifestations which are described in radiological, but it is not diagnostic. Diagnostic is only CSF. The basal exudate, whenever you see, increases the diagnostic yield of tubercular meningitis. The CT is showing various aspects and the dilatation of the third ventricle. There are areas of hypodensity which are suggestive of tuberculomas. Dilatation of ventricles is seen, and contrast enhanced has brought out the exudates which are accumulating in the falx cerebri, in the sylvian fissures, in the tentorium cerebelli. Now all around the basal cisterns are clogged with exudates, and you can see that. So you can summarize the radiology of MRI by meningeal enhancement in all cisterns and over the convexity of brain in all patients. 65% had tuberculosis. 70% of those with cranial nerve palsies showed contrast enhancement with or without thickening of the involved nerve. MRA done in 20 patients revealed focal arterial narrowing at the terminal segment of the ICA, internal carotid artery, proximal segments of the middle and anterior cerebral arteries. So these are the tubercular bacilli which are seen in our neuro-AIDS cases, which I will show you. 57 cases of neuro-AIDS. When they died, my friend and late Dr. Satyanarayan did needle necropsy of these cases, and I will show you the findings when with the practical experience of managing these cases. You can see these are our cases of neuro-AIDS which are showing tuberculomas and tubercular abscess. They have succumbed to their illness, and when we do magnetic resonance spectroscopy, you can see the lipid peaks in tuberculomas, rise in choline and creatinine ratio also you can see, and lipid peak also you can see. Similarly, this is the MR spectroscopy, because whenever you encounter a space occupying lesion, we subject these individuals to MR spectroscopy. The normal is shown here: choline, creatine, NAA and lipid peaks. Here you see more of lipid peaks. Excuse me. Hello? Hello? Yeah, I am busy with, I am in a class, call me later. Okay, so, and these are the lipid peak which you can see, then the NAA and choline ratio has changed. So MR spectroscopy will help. Another important aspect is when we diagnose tubercular meningitis and start them on treatment, these individuals may develop tuberculomas while on treatment. So we should not get worried about it. The tuberculomas paradoxically increase appearance of new lesions on different sites and improvement on ATT and surgery. So initially July 2000 you see this is a case of tubercular meningitis. In December after ATT they started having tuberculomas. We did the surgery and new lesions November 2001, and again he was subjected to surgery, and finally the tuberculomas disappeared. So appearance of tuberculomas paradoxically while on treatment should not be seen as a failure of treatment. The appearance of new lesions on ATT July 2002, this is a MRI subjected to treatment. August 2002 started having mild abnormality, and by May 2002 you see they developed tuberculomas. Continued ATT and the individual improved. So tuberculomas and CNS tuberculosis, tubercular meningitis are part and parcel of CNS tuberculosis. They should be studied together. So now after diagnosing it, we'll come into management issues. If you start pulmonary tuberculosis treatment, you know the short-term chemotherapy of 6 months 4 months or 2 months intensive and 4 months of two drug regime. And but does it suitable to tubercular meningitis? The main difference here is most of the drugs that are useful in the pulmonary tuberculosis are not useful in tubercular meningitis because their penetration into the brain is very less. The blood brain barrier prevents them from entering the brain. The inflamed meninges will allow streptomycin and ethambutol to enter, but rifampicin also has got about 20% of penetration into the brain. So then when treatment is not helping, do we do biopsy? And what is the role of steroids? Because we have seen that the main problem is activation of microglial cells, monocytes, which are releasing cytokines and various types of cytokines, interleukin 6, 10, 12, tumor necrosis factor, all these are liberated and the inflammation can be controlled with steroids. And role of surgery: if there is hydrocephalus, there is a large tuberculoma, will surgery help? Which is there are the management issues and any other. There are medicines which have been tried because tumor necrosis factor alpha antagonist thalidomide was tried with poor results. So this is the MRI image of a tubercular meningitis and a tuberculoma, and you see a lot of tuberculomas. They are not reached the ring stage, they are still scattered all, and when a differential diagnosis of cysticercosis has to be entertained here. The dorsal aspect of the spine in the arachnoid space. Then you see spinal tuberculomas, intraparenchymal tuberculomas in spinal cord, which you can see in these cases. And in our cases, what did we see? 25% cases had hydrocephalus, basal meningeal enhancement in 21%. We have seen in 14% tuberculomas, 8% infarcts, pre-contrast basal hyperdensity without giving contrast also we have seen in 4%, and normal MRI in 26% cases. So contrast enhanced MRI with flare is best for CNS tuberculosis. And to differentiate pyogenic abscess from tubercular abscess, there is a technique called magnetic transfer MR imaging or MR spectroscopy with a prominent lipid peak and high lactate, no amino acid preference also will help us in differentiating. So whenever we encounter a clinical spectrum, there is a differential diagnosis. Partially treated bacterial meningitis, we settle the issue with White score. Is it cryptococcal meningitis? In cryptococcal meningitis, the cells will be less. Viral meningoencephalitis, carcinomatous meningitis, parameningeal infections, that is the auricular abscess, the mastoid abscess, like neurosarcoidosis and neurosyphilis. These are the various differential diagnostic features of tubercular meningitis. The complications are raised intracranial pressure, cerebral edema, stupor, where we have seen the staging, basal meningitis with cranial palsies, focal neurological deficits, hydrocephalus, tuberculoma, tuberculosis abscess, opticochiasmatic pachymeningitis resulting in visual loss. That means if the exudates are surrounding the optic nerve, it can damage the optic nerve and individual will lose vision. And tuberculous arthritis and stroke, the inflammation in the medium and small sized arteries will give rise to strokes. There will be endocrine disturbances, especially pituitary gland gets involved, leading to hyponatremia, and also various hypothalamic disorders leading to loss of control of blood pressure and body temperature, diabetes insipidus, SIADH. Whenever the brainstem is involved and medial longitudinal fasciculus is involved, internuclear ophthalmoplegia, there may be some movement disorders like hemichoria. And if there is a spinal block, then you get what you call Freund syndrome, where the proteins are raised very high and cells are almost zero, and spinal arachnoiditis, where the individual will become hypertonic in the limbs with weakness, flaccid limbs with absent reflexes, and very difficult to treat condition. Metabolic complications of tubercular meningitis are hyponatremia, and 50% of the cases you see this. The possible mechanisms are cerebral salt wasting syndrome attributed to a renal tubular defect, a hyponatremic natriuretic syndrome attributed to plasma natriuretic peptide, and SIADH. So hyponatremia is one of the important findings along with in tubercular meningitis. What are the sequelae happen with tubercular meningitis? Psychological, psychiatric disturbances. As I said, opticochiasmatic enclosure of the optic nerve with X-rays will give rise to visual defects, hearing defects because it may be because of drug-induced, streptomycin-induced, focal neurological deficits, hemiplegia, paraplegia, cranial nerve palsies, endocrine disturbances, seizures, and sometimes intracranial calcification in the long term. Now, does the HIV infection makes any difference? It does not alter the clinical presentation of TBM. It's same, but there are some differences which you should identify. It affects the number and nature of complications. Basal meningeal enhancement and hydrocephalus are less common because it's a immunosuppressed state. There are more bacilli on the meninges. You can isolate more bacilli. Your Jadan staining will be more positive in case of HIV associated tubercular meningitis, which I will show you in a couple of slides later. There will be increased case fatality, increased CSF yield of AFB positive organisms. Active extrameningeal tuberculosis is more common. So are polymicrobial infections. In AIDS, if you think that he is suffering from tubercular meningitis, when you do CSF, he may harbor Cryptococcus also and polymicrobial or bacillar and gram-positive bacillar or cocci. So polymicrobial infections are also very common in neuro-AIDS. So this is our case of 57 cases. In this we have encountered about 2 cases of pathogenic meningitis, 40 tubercular CNS tuberculosis is 55, TBM 40, polymicrobials 2, with cryptococcal meningitis 3, with candida 1, tuberculoma 7, spinal TB 1. These are bacterial meningitis in neuro-AIDS. CNS tuberculosis and neuro-AIDS. Extrapulmonary tuberculosis is AIDS defining illness as per CDC criteria. Acute tuberculosis more common in HIV positive individuals. Extrapulmonary tuberculosis is also more common in HIV. Tuberculous meningitis is the AIDS defining illness in more than 3/4 of HIV infected individuals. And we have seen tuberculosis in 55 cases, pure TBM in 40, tuberculoma in 7 in one series of about 2 years study. And mixed infections with cryptococcal meningitis, polymicrobials, and candidiasis also we encountered. That is the norm in the early phases of late 90s and early 2000s. We used to have more mixed polymicrobial infections. Most common clinical presentation is fever with altered sensorium. AFB staining is positive in 10 cases of antemortem CSF and 10 cases in postmortem CSF. As I said, we did needle necropsy of neuro-AIDS cases, and then we studied the CSF also, and the CSF protein showed a mean of 100 grams, which I will show you in the tabular form. The differentiating features, you can see the CSF mean protein in TBM is higher than cryptococcal meningitis. The cell count is very less in cryptococcal meningitis. Antemortem CSF and postmortem CSF positivity, we can see if there is associated HIV infection in tubercular meningitis. And you can see the India Inc. positivity is 22 cases in cryptococcal meningitis, antemortem, and 6 in postmortem. This is our study. And cerebral toxoplasmosis we don't want to go on. Now, what are the complications of TBM? What are the types of complications which you can we have encountered? No complications. They have withstood all the treatment and they recovered very well in 53%, hyponatremia in almost 10%, hydrocephalus in 12%, and stroke in 5%, epileptic seizure in 1 case, tuberculosis in 12%, ethambutol induced optic neuritis in 1 case, rifampicin-induced fever in 1, ATT-induced hepatitis in 6 cases. And so these are our experiences of non-AIDS tubercular meningitis cases. So we have covered a long stance. Just concentrate only on tuberculomas and tubercular abscess, which you can see here, the tubercular abscess, and which is a caseating granulomas of epithelioid cells and macrophages containing mycobacteria. Tuberculoma has mycobacteria, single or multiple focal lesions. They may develop during several years after ATT for TBM or for tubercular lesions elsewhere in the body. Infrequently, caseating necrosis occurs in tuberculoma, forming a tuberculous abscess, and it usually presents as a SOL, means multiple tuberculomata can present as a headache, vomiting, visual disturbances, features suggestive of raised intracranial pressure. You may suspect tumor, but when you do neuroimaging, you can find tuberculomas. So that's one of the important differential diagnosis. And spinal involvement, epidural compression of the thoracic cord from vertebral and disc destruction by caseating granulomas. This is called tuberculosis, osteomyelitis, or Pott's disease. 1/4 of these cases, fusiform paravertebral abscesses or SOA abscesses, and there is a gibbous formation, the deformity of the spine. Extradural cord tuberculomas cause more than 60% of cases of non-osseous paraplegia also. Tuberculous radiculomyelitis may accompany TBM. Subacute paraparesis with radicular pain and bladder dysfunction can happen in tuberculosis radiculomyelitis of tuberculosis. So this is a spinal involvement. So now we'll come to the treatment part. INH, rifampicin, pyrazinamide, streptomycin, ethambutol are the primary first line drugs. INH is a bactericidal, kills rapidly replicating bacteria in first 2 weeks of treatment. Rifampicin kills low or non-replicating bacteria. Pyrazinamide kills those insides hostile to the penetration and action of other drugs. Streptomycin has got poor penetration of blood-brain barrier unless the meninges are inflamed. Means inflamed meninges, streptomycin rapidly enters. So there is a 4 drugs in intensive phase, and HR, that is isoniazid rifampicin, for 9 to 12 months. That is a treatment guideline. It is not 6 months, not total duration, not 6 months as in pulmonary tuberculosis. The intensive phase in 2 months and continuation phase 12 months. And this is a British Thoracic Society guidelines. Isoniazid, rifampicin, pyrazinamide, ethambutol or streptomycin are continued for 2 months, and isoniazid and rifampicin 9 to 12 months. And there is another CDC guidelines also, and they also give the same dose. So nowadays thinking is developing where rifampicin dose has to be increased, because the penetration of rifampicin in tubercular meningitis across the blood-brain barrier is very poor, and also it may have interaction with antiretroviral drugs, so there has to be changed. So comes the role of steroids. Corticosteroids include survival across all grades of severity. So if you diagnose tubercular meningitis, you will have to give dexamethasone for the treatment of tubercular meningitis in adolescents, in adults. All patients with TB meningitis not HIV positive should receive steroids. Dexamethasone is to be preferred over prednisolone, and there are regimes. The Thwait regime is what we follow: 0.3 milligrams per kg per day IV, followed by 0.2, 0.1 and 3 milligrams, and total daily oral dose. Reduce the dose 1 milligram each week subsequently. So route of administration is IV or oral, and you can use your discretion about this. Indians RCT of 41 patients are randomly allocated to steroids was studied by Dr. Kumar Velu and Dr. Prasad et al. All patients received the standard ATT regime. The endpoint was 3 months or death if earlier. The evaluation at the endpoint included survival, resolution of symptoms, sequelae, activities of daily living. Patients in the dexamethasone group fared much better. So adjuvant therapy, intrathecal hyaluronidase is given in addition to antitubercular therapy and steroids for spinal arachnoiditis. As I said, there's an adhesive nature of spinal arachnoiditis will cause flaccid paraplegia, weakness with areflexia, sometimes bladder may be involved. Uh, for cases of hydrocephalus, selected cases of tuberculous brain abscesses may have to resort to surgery, and the adverse prognostic factors are altered sensorium, seizures, extremes of age, high CSF protein concentration. We may have to do VP shunt for hydrocephalus, but high CSF protein may block the shunt. So usually surgeons prefer that the medical treatment should reduce the protein concentration below 100 milligrams. So resistance to one or more first-line anti-tubercular drugs is nowadays a frequent occurrence. It's a very poor outcome. Resistance to isoniazid, fairly common, and delayed CSF sterility. Pyrazinamide is a very good drug to treat. That's why pyrazinamide can be continued for 9 months. One of the important drugs of second line, ethionamide, crosses the blood-brain barrier and achieves very high concentration in the CSF and brain. The multi-drug resistant tubercular meningitis is encountered when there is a past history of treatment with the ATT, recent exposure to a known case of multi-drug resistant pulmonary tuberculosis. The PCR assay detects mutation in mycobacterium tuberculosis RPOB gene, and so there is a PCR assay which will help in rifampicin resistance, which can be assessed as soon as with the gene expert test. And never add a single drug to a failing regime. Use at least 3 previously unused drugs, one of which should be a fluoroquinoline. That is, levofloxacin achieves very high concentrations in brain and CSF. So it's important to preserve levofloxacin whenever you suspect. So levofloxacin can be used as a 4th drug in intensive phase. Other drugs include amikacin or kanamycin, ethionamide, and cycloserine. Duration of treatment should be at least 18 months for MDR. So these are the various initial phase drugs: rifampicin, aminoglycoside, pyrazinamide, ethambutol, followed by rifampicin and ethambutol 6 months. And another regime where ethionamide is included, and in the follow-up also ethionamide is included because it reaches a very high CSF concentration, and you can add ofloxacin or you can have cycloserine and make a regime which can be used in multi-drug resistant tubercular meningitis. So if you look at the finally where we can summarize in this slide, where host genotype will predispose, or HIV co-infection, pulmonary infection of mycotuberculosis, bacteremia say occurs, and meningeal and subcortical rich focus, as I showed, is formed, and this rupture of rich focus and causes meningitis, increased bacillary replication in subarachnoid space and the meninges. It will give rise to increased CSF interleukin 8, TNF alpha, interferon gamma, and also increased CSF WS neutrophils and lymphocytes, interleukin 10. What it causes is vasculitis, encephalitis, meningitis, and which will further increase the CSF lactate and CSF protein. There is a blood-brain barrier breakdown and a drop in CSF glucose, coma, infarction, hydrocephalus, edema, increased intracranial pressure. There is increase in the CSF matrix metalloproteinases, and CSF tissue inhibitors of matrix metalloproteinases are also increased. Now at this stage, you give treatment. What happens then? If you give treatment, timely treatment, and you can really decrease the basal inflammation, decrease the vasculitis, decrease the intracranial pressure with various methods which we have discussed, and individual will survive. So time to treatment is very important, and you have to keep in mind drug resistance and CSF drug levels also, and whether there is concomitant HIV infection or not. If infarctions and tuberculomas, hydrocephalus, edema are there, CSF lactate is high, and coma, cranial nerve palsy, semiparesis, death or disability will occur. That's how the CNS tuberculosis manifests in human beings. Conclusion: protean manifestations. There is considerable morbidity and mortality. There are various neurodiagnostic modalities. Still, there are many unanswered questions. The diagnosis is mainly by clinical suspicion, and CSF is a cornerstone, but it only helps, it only indicates, not a gold standard. Gold standard is culture. Gene expert is nowadays done, which is about 60 to 66% sensitivity, and it should be used only for ruling in, because specificity is high, and it cannot be used to rule out the disease. That means even if gene expert is negative, there is a possibility of tubercular meningitis present in the individual. So with that, we have gone through so many references for this lecture, and for diagnosis, etiology, treatment, we have done so much. Thank you very much, and if there are any questions, we'd like to answer. Are there any questions? About 89 participants are there. Did you follow the lecture? Somebody can type. Somebody can say, I'm removing the mute all. So now, yes, I have unmuted.
Yes, sir.
Yes,
Yes,
Bolo.
sir.
Any question?
No, sir.
Did you understand the tubercular meningitis? Hello?
Yes. Yes, sir.
Okay, good. Now you go and read. Tuberculosis is a very important chapter. So all of you should become well versed with tubercular meningitis, the clinical manifestations, the CSF findings, the neuroimaging, and the treatment and multi-drug resistant tuberculosis. Okay, then have a good day. Bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay,
Thank you, sir.
okay, Jai Hind.